A 56-year-old man comes to the physician because he has been having increasing difficulty with placing his right hand flat on surfaces. He has noticed tightening of the fourth and fifth digits over the past year, making it difficult to grasp objects but denies any pain. He has a history of type 2 diabetes mellitus well managed by medications and works as a mechanic. Physical examination reveals a tense cord-like structure in the palm of the right hand. He has difficulty extending his fourth and fifth digits, but sensation is normal. Which of the following best describes this patient's condition? Choice A, median nerve injury. Choice B, ulnar nerve injury. Choice C, stenosing tenosynovitis. Choice D, fibroblast proliferation. Choice E, diabetic neuropathy. Or choice F, autoimmune synovitis. I'll wait 5 seconds and answer the question. So basically, he can't move his ring finger and his pinky finger. However, he has no sensory loss, which is a big clue. And of course, the biggest giveaway here is this whole tense cord-like structure in the palm. This is a Dupuytren's contracture. So you get fibrosis and deposition of type 3 collagen in the palmar fascia. So choice D, fibroblast proliferation, is the correct answer. So you have this fibrosis of the palmar fascia, and over time that makes things more stiff. And a lot of times patients don't come in until they start having real deficits in function. And this patient does have some of the risk factors. Risk factors include Northern European descent. Repetitive hand use is a big one that they like throwing into questions. Like right here, he's a mechanic. So any kind of physical labor job is something they like throwing into questions. So it can be a construction worker or something. So of course, trauma can cause this. You have smoking, diabetes. And if you want to treat it, you can do stuff like collagenase injections. And in some rare instances, you might cut them open, do a fasciotomy, but that's pretty rare. So let's look at some of the wrong answer choices here. So choice A and choice B, median nerve injury and ulnar nerve injury, you can discount both of these right from the outset because he has no sensory symptoms. Or at the very least, you would put them at the bottom of your DDX, because it would be very strange to have some kind of nerve compression and you don't have any kind of sensory manifestations. As for the more specific things, talked about this before, but it is important. Median nerve injury, you want to think supracondylar fracture or carpal tunnel syndrome. You have sensory loss in the first 3.5 digits. And it can cause an ape hand because the median nerve supplies a number of the muscles of the thumb: opponens pollicis, abductor pollicis brevis, flexor pollicis brevis. The big exception you want to know with the thumb muscles is that the adductor pollicis muscle is supplied by the ulnar nerve and not the median nerve. And the other thing that can happen from median nerve injury is the hand of benediction, where you try to flex your fingers and then your second and third digits don't come down, so it looks like you're making a religious symbol, which is very easy to confuse with something with the ulnar nerve injury, which causes the claw hand, which is where you try to extend your fingers and then your fourth and fifth digits cannot extend out properly. And speaking of choice B, ulnar nerve injury, you want to think about stuff like medial epicondylar fracture or hook of hamate fracture, the latter causing injury within the Guyon canal. Now, some of you might have seen this patient being unable to extend his fourth and fifth digits and thought that he had an ulnar claw, but all the other stuff in the question, like this tense cord in his palm and his lack of sensory deficit, point to Dupuytren contracture way more than ulnar nerve injury. Choice C, stenosing tenosynovitis. So basically just inflammation of the tendon sheath. So if it's swollen, it can get bigger and it has a hard time moving, so it can lead to entrapment and then you can't extend your fingers. But if you were inflamed this way, it would usually be painful and you would have what they call a clicking sound when you try to move your fingers. Not super high yield, but it does get DDX with Dupuytren contracture sometimes. Choice C, diabetic neuropathy. Again, diabetic neuropathy is mainly focused on sensory losses, especially in the hands. I mean, diabetic neuropathy in the feet, obviously, over time it can cause injuries because of lack of sensation, noticing injuries, and then you get ulcerations and stuff. That doesn't happen with the hands as much because most of us don't walk on our hands. Choice F, autoimmune synovitis. Mainly you would think of rheumatoid arthritis, right? And this patient doesn't look anything like rheumatoid arthritis, right? So swollen joints, morning stiffness, often is bilateral. Also doesn't tend to fit the demographics, even though that's not super important, but RA is more common in women. So again, there's no swelling, there's no pain, which is all stuff that you would see in RA. And of course, often in RA questions, you'll get labs, right? So rheumatoid factor, anti-CCP is the most specific one. You can have elevated ESR and C-reactive protein, even though those are non-specific. So bring it back. Dupuytren contracture is just one of those things where once you see it, you probably always recognize it. So I just threw in some other commonly tested MSK stuff so I had more to talk about. Hope you found this video helpful. I'll see you in the next one.